So on the first page of chapter 4, determinants of occlusion principle, neuromuscular harmony depends on structural harmony between the occlusion and temporomandibular joints. And we say that all the time, but I want to just re-emphasize because today that's all we're going to talk about, the relationship between occlusion and TMJ. Okay. And this is somewhat of a, how should I put it, something that you may not really have been that aggressively exposed to in dental school, because in dental school, unfortunately, at least at UCLA, people in different sections, orthodontics and orofacial pain, they tend to dissociate occlusion versus TMJ. And today, this is sort of the restorative dentistry's uh, perspective about how they are related to each other. Okay, so when we go to page 28, okay, on the book, I wanted to start out. It says there are 10 factors that determine if an occlusion will function comfortably and remain stable. Recognizing that a goal of all occlusal therapy is a peaceful neuromusculature, the key to achieving it is to have the teeth in a relationship that is in harmony with all of these factors. Okay? Um, Establishing equilibrium between teeth and neuromusculature is critical because whenever there is a disequilibrium, the muscle will always attempt to regain it. When there is a war between the muscle and the teeth lose. Remember that. Okay, when there is a disharmony between muscle and teeth, okay, they're both casualties, quite frankly. They're both casualties, but oftentimes the teeth will lose. The evidence of this is excessive wear, fracture, teeth mobility, or movement of teeth that are in the way of jaw movement controlled by the musculature. Now, when I in a, so I when I was reading this book last night again, just to review, because I didn't want to disappoint you today. Did you actually, when you were reading, did you actually go back and see if the book had listed those 10 factors? Because it says there are 10 factors to that determine. And then I realized, I go, you know what? He's not overtly actually telling us what all those 10 factors are. Okay. And so, at least in this chapter and the next chapter, I wanted to just kind of review with you how those 10 factors sort of add up to the 10. Okay. And then I hope I am sort of following Dawson's thinking. Okay. And I think that the illustrations are pretty good in telling us. I hope that you recognize that figure 4-1, the design of the mascatory system, requires balanced equilibrium of all of its parts. You recognize that all those red lines, the elastics, this is actually a picture of oftentimes TMJ models that they sell on from various vendors. All those represent muscles, right? All those red lines. Okay, so um, sort of remember those what those red lines, what muscles and what movements that they can help us control. When we get to the musculature area, we're gonna go back and review that again. Okay, but taking a look at page 29, okay, you start out with the skull picture, okay, and I wanted to really emphasize to you all, okay, that it is the skull glenoid fossa that is the base around which mandible rotates. And I know it's obvious, but when we got trained in the dental school, and I say this over and over and over, we got trained with an articulator where the articulator sits on a tabletop and the movements that you induce on an articulator is where the maxilla moves. And it's a very subtle difference, but it makes a huge difference in reality. Okay? So just remember that. So, first, the first factor is the skull base of the skull. And then the second, you layer of a mandible, you put a mandible onto that, and there is a fulcrum where the mandible rotates, okay, around the base of the skull. And we're going to come back and talk about this when we talk about CR, okay? When he talks about hinge axis later, okay, that is what we're talking about. And this is important for us to have some idea about this, okay? So the first factor is the skull, and then the second factor is mandible that rotates around the fulcrum point. And just to let you know, okay, there is really no medical profession who knows about this or who is interested in this as much as we are. Okay. Certainly the oral surgeons are very much interested in this. Okay. And I suppose head and neck surgeons, specialized ENT doctors. Okay. But from a occlusion related things, okay, we are it. Okay. And I want to emphasize again, it seems to me like the orthodontists and the orofacial pain people conveniently forget these anatomical background. And that's where they get lost with the relationship between occlusion and TMJ. Okay. Now, it's interesting. The third picture that Dawson says is that when the mandible rotates around that fulcrum, okay, the condyle in the glenoid fossa, he says it runs into the airway. Okay. I don't know if that's the reason why God made our jaw move forward. Okay. Because this is one thing that those of you who were not here when I was talking to you, you know, as much as I have tremendous respect for pioneers in dentistry, a lot of the dentistry pioneers um, are very theocentric people, meaning that they look at the whole world view as that was made by created by God. I don't have any reason to contest that, but they will say, but I do have a concern when they say, that these were all um, made with because of these things and so forth. Um, I think it's okay to give some room for evolution. And the reason why I say that is if you look at a snake, if you look at snake's head and neck do not line up like ours. And snake has a jaw joint that is able to completely disarticulate, meaning the snake's jaw, mandible, completely dislocates out of it when they want to swallow something really big. Okay? And our jaw somewhat halfway disarticulates it basically. So when you look at the picture number 4 on the same page, when the mandible is able to slide forward and hyperflex, and Dawson says it's because we needed to breathe. Fine. I don't have any reason to challenge that. But what I'm saying is that there are other examples in our nature where their jaw does not seem to run into their airway space, okay, or their pharynx, okay, where they need to swallow food and so forth, okay. But and the reason why I say that again is because when you try to follow word by word what Dawson's saying, sometimes we get lost because it is not as scientific as we would like. At least certainly I would like. Okay. Now, so what I'm saying is the third factor is that hinge around the fulcrum slides forward, back and forth. Now, in order for it to do that, now there is a disc. Okay. So if when you think about it, you work, we keep adding layers to this system. Okay, so we have the base, which is the skull. Now we have a fulcrum, which is the mandible, the condyle. In order to allow that to smoothly rotate, not only do we have a disc, okay, like synovial joint of a knee or elbow or things like that. But as you all know, TMJ is unique in the sense that it is really the only joint in our body that is at free. It is free to slide back and forth. Not only when we breathe, not only when we eat, but as I'm talking to you right now, if my jaw did not have the ability to slide back and forth, there are certain words that we cannot enunciate. Okay, we can say God created. I don't have any problem. I also don't have any problem. Somehow evolution played a little part of it. And and the reason why I'm saying that is because as somebody who grew up in the church as a God-fearing person, okay, um, I'm not here to denounce creation, but what I am here to say is that our body has a lot of adaptability. And that's what we're going to talk about for the rest of the morning. And that adaptability is part of evolution. Okay? Evolution does not in any way deny existence of God. Okay? So I'm moving forward. Okay. So number 4 is when the jaw is able to slide back and forth. Okay? So because there is a disc there. Now, those of you who are not familiar, when you look at certain literature, they will interchangeably use the word disc and meniscus. Those are same things as far as we're concerned. Okay. Now the second picture on page 30, now you could complete all the structures within the capsule that surrounds and encloses the temporomandibular joint. So what we have now is you have the disc in between the bone in order to make sure the maxilla and mandible, okay, and the disc functions as one unit. The whole thing is wrapped around with very tough fibrous tissue that forms a capsule. Okay, so you need to, because I don't know about you, but unfortunately, when I did my first year dental school anatomy class, I was absolutely clueless what the hell I was doing. I remember opening up somebody's arm and chest cavity more than their jaw. Okay, and that was traumatic. I don't want to remember a whole lot, right? But it's important that we need to know this. Okay, so when you look at the TMJ joint itself, when you go in from the layer, when you open up lay flat, okay, you go in, what you're going to find underneath the muscle layers is going to be a nice tight capsule. Think of it as when you break a chicken's leg. It's essentially the same idea. Chicken's joint, knee joint, is held in place by a capsule that you have to break it off if you truly want to take it apart. Okay? So there's a capsule there. And then now the third picture says now that you have the mechanical parts in place, but you have no way to make the jaw function until you add the muscles. So number 6 is the muscles. Okay? All the various muscles. And you're not going to hear the end of us talking about lateral pterygoid. The lateral pterygoid is the magic muscle as far as occlusion is concerned. Okay? And then, as far as the structure that we see are concerned, the last one, number 7, is the teeth. Now you align the teeth. So the teeth, as the last guy to show up at the scene, teeth better learn how to fit within the bone and with how the muscles move. Before teeth ever showed up, muscles were there and the bone were there. And later on, you know how we say, ha ha ha, when you get old, you become like a child. Before the days of implants, when we get old and we lose all the teeth, well, the bone and the muscles are still there. So if you were to replace teeth with implants, you better have tremendous respect for the bone and the muscles. Okay? And this is what makes occlusion challenging because we are trying to control or have an impact to this entire system by working on the last piece of the puzzle. And that's the beauty of the system. Okay. Now, you guys say, well, we talked about 10 factors. We only counted up to 7. Okay. So I had to read the book a little bit more carefully and we'll get there. Okay. So page 31, we're now on to page 31. So, Dawson really wants to emphasize, and I agree with him, do not miss this extremely important key understanding regarding the relationship of the teeth to the rest of the masticatory structure. Remember that the teeth did not come in until the jaw-to-jaw relationship was established. The teeth have to fit into that pre-established maxillomandibular relationship. Those of you who went through the program with me at UCLA and had to listen to me, unfortunately, many times, remember what I said? I said, if somebody was made to be class 2, and I define class 2 by somebody's jaw movement pattern, just because the orthodontist decided you better be a class 1, well, God's not going to make that jaw and then make it into class 1. The jaw is still class 2. Okay. What does the muscle mean? We don't, most of us think about muscle as just chewing, open and closing. But this is why I emphasize learning how to do phonetic testing so much. When you pay attention to phonetic testing, you realize muscle, the jaw and the muscle coordination has the ability to move the jaw not only up and down, not only forward and back, but as it's going forward and back, it also does sideways. And if I may give you a little bit of a hint into my bias, okay? Because I'm going to come back and disagree with Dawson here, okay? So his last sentence, the teeth have to fit into this pre-established maxillomandibular relationship. Now, when somebody really wants to force everybody into a canine guidance, does that sound like the last sentence? The teeth have to fit into pre-established maxillomandibular relationship? Somehow I think there is a conflict. Okay. So I'm just using Dawson's own words to help us understand. He's laying down the groundwork for us to understand the system. And I know that we're only like page 3 right now that we're reading, okay? But this is worth a bar of gold. Remember this. Teeth are the last pieces. We have to learn to make peace with the rest of the structure. That's how you make teeth last long time. Okay? So It says principle, determination of the correct physiologic law relationship, jaw relationship, must always be determined before we can determine the correct alignment and occlusal relationship of the teeth. Yeah, he's just saying the same thing, slightly different way, right? Okay. So again, he's repeating, teeth must fit into the harmony of the jaw relationship, not vice versa. To me, that's seventh factor. So not only the teeth line up on the jaw within which the muscles move, but the teeth need to be in harmony with the muscles and the jawbone. Okay? How do we do that? By understanding the chewing pattern. And how do we better understand that? If you want to be fancy, he talks about kinematic hinge axis and articulator, and ultimately, prosthodontic approach of pantographic tracing. We'll talk about that later. But from an everyday practice, as I've always emphasized to you all, phonetic testing, phonetic testing, phonetic testing gives you a glimpse into how the jaw is moving. So second sentence he says is, that is why we all go into detail on how to establish a correct jaw relationship before we attempt to analyze, diagnose, or prescribe any occlusal relationship. Isn't that funny? He says any occlusal relationship. He wants to understand the jaw relationship before prescribing occlusal relationship. Every time you run into a patient post orthodontics, ask yourself is if there was a decision process for the jaw relationship. No, they only look at teeth relationship. That's why when you spend a lot of years in private practice, you're going to see undeniable correlation for people who have had orthodontic treatment and later in life occlusal problems. Now, as restorative dentists, from me personally, this is facetiously saying, that's great. They just create more work for me. I just feel bad for my patients. I'm not suggesting I'm anti-orthodontic treatment. No. I think orthodontic treatment, when done well, is invaluable. Invaluable. Something more than what I can do. Okay? I've taken enough orthodontic classes to understand and appreciate how difficult it is to induce that change. Okay? But I'm just saying we just need to be much more mindful of that relationship. Okay? Okay, now we're going to go down that same column, left side column, about halfway down on that last paragraph on the left side. There is a sentence that starts, it's the second sentence. Remember that the correct jaw-to-jaw relationship is established by first determining the correct relationship of the TMJ. So let's concentrate on understanding what you must know about the TMJs and why the position and condition of the TMJs is the first concern in analysis of any occlusion. And that sentence is leading us into talking about centric relationship. Okay. However, we're going to wait for that. On the right side, primary requirements for successful occlusal therapy, figure 4-3 above. Okay. So now comfortable and stable TMJ. So comfortable and stable TMJ sort of addresses all the number 1 through 7 that we had. Okay. Number 8, anterior teeth in harmony with the envelope of function and in proper relationship with the lips and tongue and occlusal plane. I like how he puts it there. Anterior teeth in harmony with envelope of motion, envelope of function, not anterior guidance. Okay? So when you go to all these occlusion lectures and they keep talking about anterior guidance, I'm here. This is why I de-emphasize anterior guidance. I'm not saying they're wrong. If anterior guidance happens to be, and that is the best anterior guidance, happens to be in harmony with the envelope of function, that is the best anterior guidance. But when that anterior guidance is forcing the jaw into certain direction, then that is not in harmony. Harmony does not force anything. Okay. Number 9, non-interfering posterior teeth. Posterior occlusal contact should not interfere with either the comfortable TMJs in the back or anterior guidance in the front. Now there's creeping in of this word anterior guidance. So people talk about anterior guidance because they don't want posterior teeth to be interfering. And that is true. If you have steep anterior guidance, you don't allow the posterior teeth to be in interference. But there is another way to do that, and that is make the damn posterior teeth shape in such a way they're not going to bump into each other, even with mild anterior guidance. Because the goal is absence of posterior interference. Goal is not anterior guidance. Anterior guidance is there so that we can have no posterior interference. But what if I present it to you? There are plenty of ways to achieve that. That is, achieve non-interfering of posterior teeth. If I'm able to achieve that, perhaps, and it is indeed the case, we don't need as much anterior guidance. Okay? That is going to be the true, okay, true, shall we say, defining moment of a stable occlusal relationship. Okay. The next sentence he says, the complexities of occlusion can be simplified if each of the above requirements is understood along with its interrelationship to other requirements. Okay, fair enough. Okay, now the next paragraph, okay, the bottom, dynamics of equilibrium. The reason we put so much emphasis on harmony between the TMJs and the anterior guidance and the posterior teeth is because even the slightest disharmony can cause severe hyperactivity and incoordination of musculatory muscle function. I agree. I agree. But I want to emphasize slightest disharmony of anterior guidance also contributes to that. So anterior guidance is not something you can impose onto the system and say, I'm going to overrule everything else. If I give you anterior guidance, all occlusal problem will be resolved. That attitude has to change if you want to learn how to do occlusion in a predictable manner. Okay. So to me, the reason why you're beginning to get a sense, like I'm going to start disagreeing with Dawson here and there. Okay. Okay. The reason why Dawson says correct things, in my opinion, right things in some aspects, but then reverts back to saying some of the wrong things later on, okay, is because they have this idea that God-made system must be perfect. And this is just a joke, but God's too busy to make all of us perfect. If we were so perfect, we wouldn't have any physical ailments. We wouldn't need adaptability if we were made so perfect. So we have a system that is not so perfect, but it works most of the times. And that does not take away credit from the creator. It does not. Okay? As it is an impressively complex system that does incredible job. Okay? And then the number 10 comes in on page 32. Okay? On the right hand column, the first paragraph, the first sentence. The first step is to have simultaneous equal intensity contacts on all teeth when the condyle disc assemblies are completely seated up in their respective sockets. The contact on the posterior teeth is on cusp tips, not on the side of the cusp, as represented by dots on figure 4-5. Okay. The lines on the anterior teeth represent continuous contact from the centric relation to the incisal edge as the mandible moves forward and laterally. The second sentence that I read, the lines in the anterior teeth represent da 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 da. That is only if you are class 1. Because when you look at the figure again very carefully, and this is the way I was trained indeed in my prosthodontic, those lines converge into a point in all the anterior teeth. That is not, you're not like misreading it, misseeing it. There's actually dots because what he said, don't get me wrong, I'm about to disagree with what Dawson says here, okay? But he says intensity context on all teeth. But let me ask you this. If all of the teeth, including the anterior teeth and the posterior teeth, contact at same time, okay? And the posterior teeth, he's emphasizing, not on the cuspal tip, not on the cuspal side, incline, but at the cuspal tip, okay? Why is it important to be in cuspal tip or at the fossa point? Because the teeth are going to be, posterior teeth are going to be loaded axially. Why was the posterior interference problematic? Because posterior interferences cause your posterior teeth to go sideways. Okay. If the anterior teeth where the lines converge, if the dots touch as Dawson expects them to touch at the same time, what will the net effect of that contact to those upper anterior teeth? It will be pushing them sideways. Okay. So to me, maxillary anterior teeth should not touch when the posterior teeth are in firm stop, occlusal stop. If they are to touch, they should touch less than the posterior teeth where they are not meaningfully laterally displaced. Okay. So to me, the number 10 is the importance of posterior support. Posterior support. Why does he emphasize all teeth contacting? Because he wants the jaw, mandible to be stable, not rocking unstable. Well, if you have enough posterior teeth, which we normally do with 2 bicuspids and 2 molars, you don't need anterior teeth for you to have occlusal stability. If you have good posterior support, your mandible your jaw joints and your muscles can be stable, just as stable as if the front teeth are perfectly touching. Okay? Now, the third sentence in the same paragraph, this formula represents contact-concentric relation and disclusion in all posterior teeth the moment the mandible moves from centric relation. Okay? I'm here to tell you that's only gonna work with perfect class 1 occlusion. Okay? And there are a good number of people who are like that, but I'm pretty sure by now you realize there are more people who are not perfect class 1 out there. Okay? The anterior teeth, the anterior guidance, assumes the responsibility along with the condylar path of separating the back teeth during all excursions. The reason for this posterior separation is because at the moment of posterior separation, almost all of the elevator muscles shut off, thereby dramatically reducing the forces on both TMJs and the anterior teeth. Okay? Now he's talking about the muscles and the so forth. We're going to get to that, so I don't want to get into that too much right now. Okay. In addition to the effects of creating a peaceful neuromusculature, note that it is impossible to overload or wear the posterior teeth during excursive movements, even if the patient bruxes, if the anterior has guidance, perfect guidance. This holds true as long as the anterior guidance remains stable and the TMJ stays healthy. This is the goal of the perfected occlusion. This is the goal of perfected class 1. And I'm here to tell you, you can still go to heaven if you're class 2. You can go to heaven if you're class 3. Class 1 is not a requirement to have a perfect life. Okay? So, Dawson and many of these forefathers in modern dentistry, they had this notion that God created us in his image in a physical sense. They have this idea about the classic Greek proportion is the perfect proportion God created. Only problem is I'm never going to look like that Greek person. Does that mean God is not my God? I have a different God? I don't think so. I think I have the same creator somehow. Right? So our science has to be applicable regardless of your ethnic background. Right? Our science has to be more fundamentally, functionally driven, not what is expected because of how we think the good Lord must have created us. Okay? And I'm not saying that because I'm an Asian and I don't have Greek proportion. I do think my, because I grew up in America, my Western perspective, I do think that I'm not going to say they look better, but the Greek proportion, they look great. They look nice. They are quite aesthetic, I have to say. Okay. But that does not mean when somebody doesn't look like that, that person has to alter themselves to look like that. We all have our own individual inner beauties and outer beauties as well. Ha ha ha. All right. Chapter 5. Okay, so that was somewhat of a review. I wanted to really emphasize that. The temporomandibular joint. And I'd imagine that many of you started having, shall we say, your eyes started rolling away when you were forcing yourself to read this next few chapters. Okay, yeah. So the first requirement is the TMJ. Okay, now he's talking about primarily the bone here, right? Okay, so the page 34. All right. The first requirement for successful occlusal treatment is stable, comfortable TMJ. Yeah, we heard that. Okay. The jaw joints must be able to accept maximum loading by the elevator muscles with no sign of discomfort. Yeah, I, I'm okay with that. Okay. We want to be able to clench and be able to have no pain. Okay. One of the most important rules to follow in dental practice is that if the TMJs cannot accept firm compressive loading with complete comfort, always find out why before proceeding with any irreversible occlusal treatment. I definitely agree. But here's the problem with the books like this. When they make this sentence, like, your patient has to be able to put, maximum compressive loading. Like, let's take a look at our patients that we saw given period, like last month or last week or whatever. How many people actually presented to you who were having pain when they were clenching? That's not a large number of people. I mean, it's out there definitely. Okay. So what I'm saying is by keep emphasizing that too much, the author of this book loses those of us who are mere average everyday dentists. Occlusion is a bigger problem, even if they're not causing pain when you are clenching. By emphasizing this too much, we tend to start thinking like, oh, this is not concerning us. Okay. Um, but this is something to keep in mind because this will play a factor in definition of CR later on. Now, he goes on to say, it is only through understanding of how the normal healthy TMJ functions that we can make sense of what is wrong when it isn't functioning comfortably. Okay, I agree. And this is exactly the same reason why I keep telling you to practice phonetic testing. Keep practicing phonetic testing with normal patients first. So you understand what normal people with no complaints, how their phonetic pattern moves their jaw. Then when you see somebody with pathology, you go like, oh, that looks different. If you only want to study pathology, I mean, it's kind of like this. If you want to study occlusion only when things are wrong, it's kind of like you going to medical school or dental school and say you want to be a pathologist, but you want to skip biochem, you want to skip histology, you want to skip anatomy, you want to skip microbiology. Does that make sense? Absolutely not. Okay. So if you want to study, okay, malocclusion, you have to understand good occlusion first. Okay. Let's take a look at the right-hand column on page 34. He talks about he talks about the articulating surface. If we examine a dry skull, it is apparent that the articulating surface of the condyle and its reciprocal socket merely allow movements to occur. The condyle is often described as a universal joint, but that description does not apply because each condyle imposes limitations of movements on the other. For those of you, so I looked up the definition of universal joint, okay? Basically, it's ball and socket. So your elbow, your knee, okay? Universal joint. But what he's saying here is, but you have to remember, right condyle is connected to the left condyle. Your right arm is not connected to your left arm. So your right arm elbow is so much freer to do what it wants to do. But for us, they are connected. So when you are chewing food on your left side, it also has an impact on the right condyle. And the right condyle influences what happens on the left side when you chew. Okay? One condyle cannot move in any manner without reciprocal movement on the opposite side. Okay? In opening closing movements, the two condyles form a common axis and so, in effect, act as a single joint. So there are two separate joints, but oftentimes they act as a single joint. So in prosthodontics, we try to separate that by having concept called, okay, kinematic hinge axis. Kinematic means movement, right? So when right condyle and left condyle function when we are opening and closing and when we are talking and things like that, they are moving as a one unit. Okay? So we call that kinematic hinge. And then there is a different school of thought. They say, well, they are two separate things. They both would look sometimes different. They each look sometimes different. And, da, 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 da. And then we call those people or those concepts anatomic hinge. Okay. They are both applicable in certain situations. Okay. But you just need to remember they are connected. So what you do to your right teeth, right side teeth, has an impact on when the left side teeth are functioning. Indeed, if you look at embryology, when we are mere fetuses in mommy's womb, rather, okay, our maxilla and mandible come separately from each side, and they fuse together to become one bone. You know, we don't have any problem accepting that when we think about cleft palate, because we see that all the time. Not all the time, but often enough. Okay. But we don't see cleft mandible most of the times, right? Not yet. But here's the thing. If there is embryologically active fusing point in the front, no wonder there is a lot of teeth movement in the front of the jaw. Okay? Because they are indeed, after all, embryologically two separate pieces that decided to work together. Okay, the last sentence, okay? Despite the fact that the condyles are rarely symmetric, okay? So the right condyle, left condyle, they are not perfectly symmetrical most of the times. The axial rotation occurs around a true hinge that is on a fixed axis when the condyles are fully seated. And that is an imaginary axis that goes through. You see the line, red dotted line in figure 5.2, okay? That goes through between the two medial points of the condyles, right medial point, left medial point. Okay, I'm not gonna try to get ahead of myself. Rotation around a fixed horizontal axis seems improbable because of the angulation of the condyles in relation to the horizontal axis. So if you look at the condyle themselves, each condyle, you see how they are tilted. Condyles are somewhat perpendicular to the occlusal direction of that quadrant, right? You look at the mandibular teeth on the left side, the condyle on the left side is lined up perpendicularly. But because right condyle and left condyle are tied together, and because our mandible is not a perfect U shape, but some deviation of a V, okay, the most posterior fulcrum point becomes the medial point of the condyles. And this is important because later on you realize there is also disc there, or part of the disc covers that medial space. So figure 5-3, look at that. Now that's a cross section of your condyle. See, we tend to look at disc picture only through the figures like 5-1 on the opposite side. We only look at it like that. So we think disc only goes back and forth, front and back. But the disc wraps around to the right side, to the left side, to the lateral, and to the medial. So your disc actually has the capacity to be slightly dislocated in any direction or completely dislocated in any direction. In fact, when you look at that disc picture on 5-3, it's thickest towards the medial point. It is not an even thickness. Okay? All right. So I'm going to keep on reading, listening to what Dawson had to say. The last sentence on the left-hand column, okay? Because of the different angles and the asymmetry of the condyles, the medial pole is the only logical common rotation point that would permit a true rotation to occur on a fixed axis. For the medial pole to serve as a point of rotation, the articular fossa must be contoured to receive it. And that is the picture of figure 5-4, the center point of that arrow. Okay, that's what he's trying to say. Its triangular shape serves this mechanical function very well. And in addition, the medial part of the fossa is reinforced with the thick bone, so it can also serve as a stop for the upward force of the elevator muscles and the inward force of the medial pterygoid muscles. Other than the strongly braced medial portion, the roof of the fossa is always quite thin. So again, going back to figure 5-3, when you look at that bone on the maxillary member of that bone, you see how the medial side and the lateral side are reinforced, but not so much in the midpoint of the glenoid fossa. Okay. All right. Now let's go to the next page. One thing that we don't think about often is that picture of 5-5. So that's a picture of medial pterygoid, right? So medial pterygoid holds the jaw like that. Now, I actually, now that I think about it, I should probably look it up and then come back to you on that. But between medial pterygoid and uh, buccinator muscle, right? No, I'm sorry, masseter muscle, the one that essentially goes the similar direction, but from outside of the jaw, on the lateral side, outside of the jaw. Okay. We see the masseter muscle bulk up a lot more, right? But when you look at that, you would take a look at it, that mandible picture. So if you were to imagine if there is no masseter muscle and only medial pterygoid muscle was functioning, you could see how the mandible can actually be kind of, if you look at my hand, if this is the right and left mandible and the medial pterygoid is only on the inside, you could see how the mandible will tend to do this, turn a little bit. Okay. The reason why I'm saying that is because the Masseter muscle has almost the opposite force. It will make your mandible go like this. You have to remember, mandible is a living thing. The reason why I'm saying this is because the shape of our bone changes throughout our lifetime, okay, depending on the force onto which it is applied. So if somebody becomes very much of a clincher, grinder, not only are their masseter muscles become developed, but because masseter muscle is able to exert more force than medial pterygoid, your mandible starts to have more, instead of the straight up and down, they start to have a more leaning appearance. And guess what that will have, what will do to your occlusion? It literally changes how your teeth are lined up. Okay? And you're going to see that as you start seeing elderly patients, more and more elderly patients. Okay? Now, um, on page 36, needless to say, TMJ is designed as a load-bearing joint. Okay? And the second paragraph, it says the articular eminence forms the anterior part of the articular fossa, and that is the maxillary member of the jaw. Because of the slightly forward pull of the elevator muscles, the condyles are always held firmly against the eminence with the disc interposed. So if you read the book, portions of the book, you're going to hear Dawson keeps talking about superior position of the condyle. Okay? But if you look at the picture of the figure 5-6, okay? He is actually trying to describe why the disc doesn't slip to the back as much or whatever. But when you look at that, it's demonstrating the force goes not only straight up, but slightly anterior. Okay? Would it not make sense for the disc to be slightly anterior from the superior? Right. So Dawson's definition of CR is not in agreement with prosthodontic definition of CR. I'm getting ahead, but I didn't want to miss the chance to point it out to you when it first became obvious to me. Prosthodontic definition of CR is that the condyle and the disc is slightly superior anterior, just as Dawson's own diagrams show us. Yet, Dawson keeps talking about only insisting on superior position of the condyle. If the condyle is indeed only directed superiorly, you are more prone to disc displacement indeed. You want stable condyle, you want stable TMJ, the condyle and the disc has to be slightly anterior from superior position. What do I mean by slightly? Well, that's going to depend on individuals, the way that their bone was formed. Okay. All right. So, um, I think that's enough of this chapter. Okay. Maybe I should just emphasize here on the page 37, just a few things that I want to make sure that you didn't gloss over it. Okay. On the left-hand column, second paragraph, as further evidence that this is a stress-bearing joint, all of the articular surfaces of the condyle, the fossa, and the eminence are covered with avascular layers of dense fibrous connective tissue. Again, I go to, I'm sorry for those of you who are vegetarians, but I go to the analogy of chicken bone. I go to the analogy of any meat stock that you cook and you make a soup. A lot of traditional cultures will make a bone broth soup, and they will throw in the joints. And when you take a look at them afterwards, after they were cooked, you will see that they have this very fibrous, avascular joint. Okay? The absence of blood vessels is a sure sign that these specific areas are designed to receive considerable pressure. The avascular areas are also devoid of innervation, so they don't hurt as much. Right? All right. The second paragraph, the one down, the disc itself is a classic example of design for function. It is composed of layers of collagen fibers oriented in different directions to resist the shearing effect that might occur in a sliding joint. The bearing area is avascular and it is nourished by synovial fluid. One more thing you need to remember, synovial fluid, that is that also lubricates the joint in smooth gliding function. The synovial fluid is kept in place within the capsule. Now, the capsule is not perfectly impermeable, so synovial fluid can escape a little bit, but for the most part, it is locked into that space by the capsule. So synovial fluid is, you can think of it as basically like the grease, oil, literally, right? The reason for using collagen fibers instead of hyaline cartilage in the TMJ is that the stiffer cartilage that works well in most other joints, okay, in the body would not be pliable enough to change shape as it conforms to the contours of the convex eminence and the sliding movements. So I want you to remember TMJ joint disc or the meniscus is fundamentally different from the cartilage that we have in our spines or in our knee joints or our elbow joints. They tend to be more like cartilage, but our TMJ joints are much more fibrous. And the advantage of this design is that it allows it to be shaped differently as needed when the mandible or the condyle moves along the eminence space. It is not dictating a certain shape. It's a beautiful system. But because it does so much, what do we know about from our daily lives? When something does so much, guess what? There is a higher tendency it can also misfunction. It can start to break down. Okay? And that's what we are trying to learn here. On the right-hand column, the disc is firmly attached to the medial and lateral poles of the condyle. And such attachment is the reason it moves in unison with the condyle. Okay? The disc ligaments, which binds to the disc to the pole, allow it to rotate from front of the condyle to the top and vice versa. In normal function, the disc is always positioned so that pressure from the condyle is directed through the central bearing area. Positioning of the disc is controlled by the combination of elastic fibers attached to the back of the disc, which keeps it under tension against the action of the superior lateral pterygoid muscle that is attached to the front of the disc. So while the discal ligaments pull the disc along, the condylar moves. Its rotation on the condyle is determined by the degree of contraction or release of the superior lateral pterygoid muscle. Okay, so that's somewhat confusing. Let's go back and take a look at the figure 5-6. You see the yellow on top of the condyle. And you can think of that as the disc, the fibrous tissue. The front part of the disc becomes or is attached to superior belly of the lateral pterygoid muscle, which is colored slightly differently. The posterior part of the disc is attached to again, the attachment to the neck of the condyle in the back as it slowly, gradually becomes a different color. The back one, the retrodiscal area, okay, the back one does not have a muscle in it. So only thing it is like a rubber band. It stretches. When does it stretch? When the lateral pterygoid from the front pulls on the disc towards the front. Then the back tissue will stretch, allow the disc to move forward a little bit. If the lateral pterygoid is not contracting and forcing the disc to come forward, then the elasticity, the rubber band from the behind, it pulls it back into its position. So it is the lateral pterygoid that profoundly affects the location of the disc. Okay? It's probably more important for you to remember the disc is not sitting there passively. The disc that I understand, the cartilage disc for my elbow, my knee, my cervical spines, they are all there passively. The discs in those joints are not designed to move around on a needed basis. But TMJ joint disc is able to move. So in a way, maybe we shouldn't call it disc, right? So that we don't get confused. But regardless of what word we use to describe it, okay? You want to call it fibrous tissue or whatever, okay? Okay. You need to remember it has the ability for it to move because of the innervation from the lateral pterygoid. Okay. Now, the last paragraph. Many of the misconceptions about the disc have resulted from its depiction in illustrations as a little round cap that sits on top of the condyle. Okay, many of the misconceptions comes with the illustration, right? That is a round cap, right? Little like our cervical spine, right? Well, guess what? That's exactly how he himself depicted it, going back to page 29 and 30, when we were adding in those different parts, components of the mascatory system. Okay, and this is indeed exactly the reason why we keep getting confused. Because when we are trying to make certain illustration, certain explanation, we, in order to oversimplify it, indeed, we kind of make it a little confusing later on because we oversimplified it. Okay? But now we have a more complete picture. You know, I thought about showing you part of one of the slides from my lecture showing the cross section of the TMJ. Do you remember? Okay. I think seeing that at this point will be helpful. When we have a break time, I'm gonna pop up my lecture so we can go back and forth and look at some slides to make a point. It's gonna take me a little too much time right now for me to go look that up, so I'm gonna right now skip it. Okay. So when you go to the page 38, now he goes through a few points of making a point of dispelling the misunderstandings of condyle disc alignment. So the first misunderstanding, he says, medial lateral discal ligaments. Okay, the disc is designed to rotate on the condyle like a bucket handle that attaches to the medial lateral poles of the condyle. So the disc's job primarily is to slide forward and back. But as it's doing that, as you're looking at that picture, there's a center point at which on either side of the condyle where they're primarily attached to. Okay. So, so they are firmly attached to the condylar neck in either side until they are dislocated. But if they are normally functioning, they have firm attachment medially and laterally. Okay, and then there is the posterior ligament. Okay, the disc is tethered to the back of the condyle by an inelastic band of collagen fibers. This prevents the disc from rotating too far forward. It also prevents the disc from being displaced anteriorly. Same thing. Okay. The disc cannot displace anteriorly if the posterior ligament is intact. It must be stretched or torn to permit any forward displacement. Why would it be stretched or torn? They sort of come together hand in hand when the disc keeps on getting forward too much. And I'll share with you one of the main reasons why disc gets pushed forward. Superior elastic stratum. Elastic fibers bind the disc to the temporal bone behind it, retrodiscal tissue. There are some, elastic fibers also attached to the posterior aspect of the eminence. Okay, and maintains constant tension on the disc towards the distal. So that again, all these elastic tissues are holding the disc in place, but they are not strong enough to directly oppose the functions of the superior belly of the pterygoid muscle, lateral pterygoid muscle. It is only when the pterygoid muscle relaxes that these elastic things will pull it back. Okay? And then the last one, superior lateral pterygoid muscle. Okay? If all the connective tissue attachments to the disc are designed to prevent the disc from anterior displacement, how does a disc become anteriorly displaced? The only forward pulling force that could anteriorly displace the disc is the muscle that attaches to the front of the disc. It is this muscle that, in combination of the elastic fibers behind the disc, controls the position of the disc on the condyle. So it is always aligned with the direction of the force as the condyle moves down the slope of the eminentia. Okay. Now that explanation, to me, I think was a little bit off the mark, but I'll just say that superior lateral pterygoid muscle is something that we need to always remember. Okay. Now, the page 39, okay, when you are starting to open, so take a look at that picture again. Again, Dawson is demonstrating the disc is not only on top of the condyle perfectly, it is positioned anteriorly. The condyle is predisposed to moving forward. Condyle feels it is natural for it to go forward as much as it's opening and closing. Okay, so as the drawings demonstrate there, maximum opening and closing. It doesn't even have to go maximum opening. Okay, when it opens, I think Dawson quotes a study that says approximately we can open our jaw about 20 millimeters in pure rotation before the condyle actually starts to displace forward. We use that word translate in order to describe the sliding motion of the mandible forward. Now, this is the thing to remember. Our mandible is capable of doing rotation and sliding at the same time. It does not only rotate and then slide only. So when you are eating food, when you are talking, this rotational movement and sliding movement are occurring simultaneously. That's number one. And because we only look at one joint at a time, we we subconsciously assume that right movement and left movement is unison. It is not. For many people, when you're looking at them from front of their face, okay, you notice that when they are moving, some people's jaw pulls to the right, pulls to the left. Okay, so 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 the jaw joint has different movements between right and left. They are connected, but they don't necessarily move the same amounts. When we talked about kinematic hinge axis, it's the vector amount. It's the sum and divided by 2 amount of the right and left movement. Okay? So take a look at the picture on page 40 when they are in full closed, okay, um, uh, movement, a function, position, okay? And you can see how the disk's job is able to slide forward and back, okay? Now, these are kind of, you know, just kind of like marching forward, but bear with me, okay? Because we need to get to the land of centric relation discussion when all these things start making sense, okay? And why understanding this is important. Page 41, on the left-hand column. The temporomandibular ligament of the joint does not come into function until the jaw opens to 20 millimeter or more. At that point, the ligament reaches its limit of length and stops the mandible from opening further in centric relation. So here's the one thing that Dawson doesn't talk about later on. And this is part of the definition from a prosthodontic perspective. That's why I'm bringing it up to you now. And that is part of the definition of centric relation is when you have that, okay, what he just said. When the ligament reaches its limit of length and stops the mandible from opening further in centric relation. In centric relation, your jaw is able to have perfect rotary movement, the 20 millimeter. If you force somebody to be anterior to that by opening big, you're not in centric relation. So when the patient volunteers, when you put your bite registration material, which we'll have a discussion on later, because that was one of the topics we discussed in the book. When you ask somebody to open their mouth so that you can put your bite registration material onto the teeth, almost all of them will open their jaw beyond 20 millimeters so that you can put stuff into their mouth. So if the patient closes their jaw immediately from that position, there are higher probability the jaw may not go all the way back as they're closing because the closing function and sliding back function is occurring simultaneously. So one of the ways that, because I'm sure I'm going to be sharing with you later on, how do I how do I discern centric relation is after I place the material in their jaw, I want you to quote and unquote close their mouth only halfway and relax first. Why do I say relax? Because when your jaw is coming forward, if your jaw is forward, it is not relaxed. All the muscles are firing to hold the jaw forward out of its socket. If the muscles are at rest, then the condyle will be within the 20 millimeter of rotational range. So what I invite people to do is, and to a lay person's ears, if they can follow what I say, I tell them, go ahead and relax your jaw. Then you're going to notice the jaw usually drops back. From there, you just invite them to close and rotate up. Because once the jaw is relaxed, it is in CR. And we'll have plenty of chance to talk about CR more, so I'm going to stop here for that. But I just wanted to just let you know the importance of what Dawson said about, that it is in CR when you are in a rotation or when you get out of CR when you are beyond the range of the rotation. Okay. Now, the next paragraph, okay? The temporomandibular ligament is not a factor in centric relation as it is not at its full length when the condyle disc assemblies are fully seated, unless the jaw opens 20 millimeters or more. Okay, so he's like saying the ligaments don't play a factor. Indeed, centric relation is a bone-to-bone relationship. Even the disc is not that relevant. Why is that? Because Dawson talks about adapted centric relation, right? So we need to be able to function with healthy as well as adapted functional relation. So I'm not going to say, it has to be in the center and this and that and all that, or the disc has to be in a perfect position. Because what if the person has a ill-formed or malformed disc? Okay, so centric relation is bone-to-bone relationship that occurs with no translation when the joint is able to do pure rotational movement. That's a very simple centric relation definition. Misconception about joint physiology and anatomy, the bottom box. Some authorities have claimed that centric relation is not a physiologic position because it is a border position in which joints do not normally function. This concept is based on a misconception about joint physiology and anatomy, as well as a lack of misunderstanding of centric relation. All joints, including the TMJs, function in a fully seated position in their sockets. Just as the joints in our legs are fully loaded in an endpoint of compression. The condyles are similarly loaded in centric relation by the elevator muscle. The misconception comes from confusion about a fully packed position at the endpoint of ligament length. Centric relation is not a ligament braced position, but rather it is a physiologic endpoint that is achieved by coordinated muscle functions during jaw closure. The condyles must be forced distally down the posterior slope of the fossa for several millimeters from centric relation to reach that endpoint of ligament bracing. That last sentence is kind of unnecessary and confusing you, But let me put it this way to you. Centric relation, that word, that nomenclature, throughout throughout dental history was used for different purposes. And that's where a lot of confusion comes in, and different authors say different things. I dare say to you this way: it is important to understand the concept of centric relation, but it is more important to understand the jaw needs to be able to function at a physiologically stable position. Now, you notice how when I just described how I want the jaw to function in a physiologically stable position, I didn't use the word centric relation. It, I think, in my opinion, I think centric relation and the physiologically stable position should coincide together. They should be the same position. And when you use that concept, then you're going to start to depart from what Dawson's going to say later. And to me, that's the natural progression in our thinking. What is the natural progression coming from? Going all the way back, about 100 years ago, when dentists started to learn how to make dentures predictably. Not like George Washington, where they made a plaster impression of the jaw and they literally carved out ivory or wood or bone to make it fit onto the jaw. About 100 years ago, they started to learn how to make porcelain teeth and what they call vulcanite, rubberized base. Before they had predictable acrylic, they were using gum-like, rubber-like things for holding on to the denture teeth to be fitted onto the mold of the jaw. And as they were making that denture, they had to learn how to mount upper part and the lower part. They had to make something called articulator so they can play with it and learn how to set the teeth. And when they studied how the jaw moved, they came to the conclusion, if I move my jaw forward, back, and if I move my jaw left, back, and if move my jaw right, back, they realized they came to a point. Okay? And that's, those of you who are wondering, that's the Gothic arch tracing. And that point where those three lines came together, they decided that's the most retruded position, but this is where we think is most repeatable, which it is. And they said, we're going to call this the centric relation because this is where we want to set the teeth at. And from there, we're going to allow teeth set up to allow forward, back, right back, left back movements. That is the beginning of this concept called centric relation. It was so that they can mount a stupid maxillary and mandibular member on an articulator and set the teeth. And then dentistry became more complex and sophisticated, and we started working on teeth. We started making crowns on teeth. And then we realized, well, you know what? Guess what? We're going to be making crowns on teeth. We're going to be doing full mouth rehab. Now we need to be able to mount this just like denture so we can do our wax up and cast our gold. And what's the best position to do it? Well, we should do it the best way that we were doing it with denture. So that concept moved over to fixed prosthodontics. But as we're doing that, our science developed more and developed more. And then we said, oh, maybe we should take a look at the actual condyle. Maybe we should take a look at the actual disk. Now we started making relationship, how they're correlated to each other. So it was no longer just retruded, that was good enough. Now we're going to say, oh, it has to have certain relationship with the disk. And then the first wave of theocentric, God-centered clinicians, because they were God-fearing clinician doctors, they said, just like Greek proportion, well, we have a socket and we have a bone. Don't you think it makes sense? The condyle should be at the center of the socket. Yeah, it makes sense. And they were looking at basically, they were not really good at gross anatomy yet. So they looked at the skull samples. And so when they're looking at bone to bone, they say, yeah, it makes sense. So they started to say, okay, some people call the rearmost, midmost. Okay. And then some people started to call this most superior because we are supposed to have a disc on top of it. But then when they looked at more and more, now they had what they call EKG. I'm kind of getting ahead in the book. Then comes all this super duper research starting in the 60s and into the 70s about EKG. They are able to isolate each muscle group and record EKG from each muscle group. And then they started to realize, oh, it's the lateral pterygoid that's holding this. Masseter muscle is doing this. Temporalis muscle is doing this. They have a better imaging technique now with the radiographs. And they go, oh, guess what? The disc is actually slightly anterior. So the late 70s and 80s, there were a lot of discussions or arguments rather within dentistry. So the idea about superior anterior positioning of the condyle and the disc actually got popularized or was proposed in the late 70s. But there were still some people who were holding on to the idea of a superior position, like Dawson, into the 80s. Okay? But a lot of that knowledge came from the research that places the position to the superior anterior. And that's why a lot of these diagrams actually indeed are demonstrating superior anterior. But these God-fearing people, they can't get away from the concept. It must be harmonic. They look at Greek proportion, the golden proportion. They're trying to get somehow some God message. There must be some sort of a geometric pattern that we're missing. These are the same people 100 years ago, well, not quite 100 years ago, in late 1800s, some guy named Monsoon came along and said our occlusal plane should have approximate resemblance of a perfect sphere. That if you put that in the midpoint of your base of your skull, our occlusal plane should be the half sphere. That's where the word monsoon sphere comes from. To them, and this is what I mean when I don't get to elaborate on this when I do lectures, so here I am. This is what I mean about when all these people are disciples of Newton. Everything is perfectly aligned in what they can see. God created the world perfectly. And again, I'm not trying to bash these God-fearing people. But to them, they didn't differentiate anatomy from theology. Their idea of anatomy got mixed up with theology. And all I'm trying to tell you here is we should be doing a little bit better in separating theology from science. Just like how theology should have no play in politics. Ha ha ha. I had to say that. Okay. So the next sentence here we go. The on the right hand column, he says arteriovenous shunt. As each condyle disc assembly moves down the eminence, it evacuates the space up in the fossa. Nature cannot have a vacuum. You see how the words that they use. Why does it have to say nature cannot have a vacuum? Was that a necessary phrase? Okay. I think there another perfect way to say is that we have an enclosed system. So when the retrodiscal tissue must expand to fill the space evacuated by the condyle and disc, that there is a subsequent function, a dimensional change that occurs. So there are other ways to describe the same thing that's happening instead of saying the nature was meant to be this. Okay. It does this by rush of blood into a network of vessels that are spread through the spongy retrodiscal tissue. Blood vessel walls are elastic, and the expansion of the vessels fills the space. And all those are perfectly fine description. Just don't say the nature cannot have vacuum. The nature is very mysterious, isn't it? I always found it to be, maybe I'm kind of off the wall, you know, you know, um, the one of the first things that we learn when you take high school biology is that life does not come from uh, uh, non-life forms, right? Well, if you look at science about evolution, you know, yeah, sometimes I wonder about that statement. And then another axiom about like real fundamental basic biology is like, when you have a dog, you're not gonna get a cat, right? Dogs keep making dogs. Well, but then, wolves became dogs. And we have so many different species of dogs. Some of them don't like dogs to me at all. Give it another 1,000 years. What's going to happen? And that's what I mean about evolution. And the way that we're thinking, we need to be open locked. We need to be an open system. You know, it's a half joke. Don't be an iPhone. You have to be an Android. You have to have an open system to be willing to evolve in thinking. You cannot be only locked into one way of thinking when you want to be scientific. Okay. So the second paragraph, I guess, on page 42, this arteriovenous shunt, also referred to as the vascular knee, is an important part of the intracapsular structure. Intracapsular, within the capsule. Okay, it makes the retrodiscal tissue highly vascular and richly innervated. If the disc is displaced anteriorly, the condyle loads into this tissue and causes pain. Now, I'm going to read that sentence one more time because every time I read it, I always misread it and I have to pay attention. If the disc displaced anteriorly, not the condyle, if the disc is displaced anteriorly, the condyle loads onto this tissue and causes pain. Now, it's about time that I'm going to say, when does the disc tissue, when does the disc displace anteriorly? I think one of the best ways that I can illustrate that, I'm gonna go back to page 32. Take a look at figure 4-6. Now that drawing is designed to show you what happens when the condyle comes down and posterior teeth are separated. Okay. But just follow me. What if you have a scenario when your anterior teeth over erupted, or you don't have posterior teeth, or posterior teeth are short? So if the front teeth are the only ones that are touching at the lingual incline of the upper front teeth, and if somebody kept clenching and you don't have posterior teeth touching to stop the condyle from going upward, what will be the net effect of that? The net effect of that is the condyle will not only go up more, but because of the incline of the upper anterior teeth lingual surface, the mandible gets pushed backwards as a whole body. And when the mandible gets pushed backwards as a whole body, because the disc is held in place superior anteriorly, now you take a look at the picture on page 34. Take a look at the picture. Take notice number 3, the disc, where the disc is. But what if number 2, the condyle, keeps getting pushed posteriorly because you don't have adequate posterior support, or you're missing posterior teeth? What will happen is your condyle and articular eminence starts to get some gap in between, because your condyle wants to keep on going towards number 6, number 8. When it's going back, there is bound to be a little bit of gap that forms. Minute initially, very minute, but eventually much, much more. And as it's doing that, what is the disc gonna do? The disc now has freer play, and because it's predominantly tilted towards the front, the disc can slide into the front. And what is if you're looking for like a significant event that happens, that would be when somebody yawns really big, people who already have had occlusal problems. So their disc is unstable. And then when they yawn really big, the disc and the condyle comes forward, but then they overstretch. Okay. So the times that when, I just had to emphasize that to you. Okay. Uh, when does that happen? When does the disc go forward? It's when you are lacking posterior support. Okay. Okay. Now, where was I? I got little excited. So I'm on page 42, right? That's when I went back, right? Okay. So now let's go back to the articulation topic here. Okay, so most of the confusion about occlusion-centric relation and TMDs are the result of wrong information about the structure of the TMJ articulation. The most prevalent misconception concerns the capacity of the TMJ to accept compressive loading. A typical example of the erroneous viewpoint is taken directly from the orthodontic literature, but it expresses a belief shared by many. Compression upon the TMJ intracapsular components is not well tolerated. This erroneous depiction of the TMJs represents one of the most prevalent causes of confusion. Everything about the design of the TMJs points to capacity to accept compressive loading as the fulcrum for the mandibular level. I think, in my humble opinion, I think both sides are correct. The system is designed to take a lot of loading. There's no doubt about that. Okay? But that's when it is working well. When it is not working well, it cannot take too much loading. And that is why many of you who have spent some clinic time with me, you have heard me tell the patient what? Don't eat too many stupid almonds, especially when they have other occlusal problems. Okay? If they have perfect occlusion, be my guest. Go to Costco, pick up the 5-pound almond bag and finish it if you like it that much, if you like to punish yourself. All right? And chances are you're going to be fine. But if your system is already on tethers, okay, then you're more likely to have a problem. And this is exactly one of the problems that, not problems, one of the shortcomings that I see Dawson's book has. They are trying to make, and I know that many other speakers do, they're trying to make definitive statements all the time. Whereas you may get frustrated at me because I tell you it's not really black, it's not really white, it's actually a gray. It depends on how the light reflects upon it. That's what clinical science is. You know, as we all went through COVID recently, okay, sure, you can have a situation where you're completely COVID free, you're completely submerged under COVID and miserable. But many of us have also experienced COVID-like symptoms, or that it takes a long time to get out of COVID. You don't have COVID one moment and another moment you're completely free. You know, biology is all about different shades of gray. And same thing with occlusion. Okay? So that's number one. Okay. Number two, another misconception, okay, is that the articulation of a TMJ is very compressible, akin to rubbery foundation that prevents the condyles from having a stable, definite stopping point in their sockets. A quote from the literature expresses this viewpoint. The natural condyle fossa relationship has 2 to 4 millimeters of superior joint space. Under the forces of the masseters, temporalis and medial pterygoid, this space can be overpowered and compressed. I mean, I could see some situations they are and some situations they are not. Again, don't be so gung-ho about this compression and this and that. Okay? You know, it's all different shades of gray. Now, on the last paragraph on the left-hand column, I'm going to go down to the second from the last sentence. First, it fails to recognize that the stopping surface for upward movement of the condyle disc assembly is hard bone, not a sponge soft tissue. I'm going to say, no, Dawson's wrong on that. It is not hard bone. There is meniscus. It's not as soft as spongy. It is a very tough, fibrous tissue. It is not bone to bone, at least if the person is alive. And this is exactly what I mean. It is not one side, it is not the other side. It is gray. And these people spent their lifetime talking, it has to be white, it has to be black. No. Okay. And then Dawson goes immediately on to say the same correct thing. Okay. The disc that is interposed between the condyle and the bone stop is dense, strong, fibrous tissue with no blood vessels in its bearing surface, with no clinically observable compressibility. Really? No clinically observable compressibility? Again, Dawson oversimplifies it there. Why? Because they're only thinking about the bone. Of course, the tissue, the meniscus is compressible. Not only that, not only that, within the capsule, what did I tell you that was also there that's meaningful, that lubricates? The meniscus is slippery, but there is one more thing that was making it much, much more slippery. Remember? Synovial fluid. Now, imagine you have this synovial fluid filled cartilage or fibrous tissue. It's going to act like a balloon, meaning when you compress one area, the synovial fluid acts as a lubricant and as a cushion. The fluid displaces out a little bit. It doesn't displace, some of it I'm sure will exit the capsule because the capsule is not perfectly impermeable, but much of it is inside. But what it does is it goes into different spaces of the capsule. And this is why when Dawson says CR can be recorded with pinpoint accuracy, he is wrong. Because we're not measuring teeth to teeth, which he acknowledges. He says it's bone to bone, but no. Between the two bones, we got this fibrous tissue called meniscus. The meniscus is filled with bathing in synovial fluid. Okay. And this is the reason why I choose to read this book with you, because this is what you are hearing from other people. Repetition from Dawson. They think that quoting Dawson is like quoting Bible. I'm not going to claim Quran because I don't know enough about Quran. And I don't want to say anything blasphemous, so I'm not going to go there. Okay. And I don't know enough about Buddhist scriptures, although I read a few lines. Okay. But I actually did spend good amount of time with Bible, so I can say that. Okay. But guess what? Bible is not meant to be read literally. Neither is Quran, neither is Buddhist scriptures. There are plenty of examples in there that we are supposed to read them in context of the whole thing. And such is our understanding of our nature. We need to understand nature in context. Okay? Don't be hung up on only one little thing. That one little thing can be very, very important, but it cannot be in absence of everything else. You still have to remember all the other things that are in at play there. Okay. So after that sentence, when the condyles are completely seated, he says it's in centric relation, that centric relation. The inferior lateral pterygoid muscle is completely released and is inactive even during clenching if there are no deflective tooth inclines to interfere with complete seating of the joints. Now we're starting to throw in other layers to understanding. We'll come back to that later, okay, when we talk about the muscles. Okay. Now we're gonna go on to the next paragraph. Okay. Nakazawa, okay, describes the upward forward position of the condyles in the splenic fossa, a very stable position even under considerable stress. It is obvious that the compressive force at the joint produced by the musculatory muscle is not harmful. Since the disc is composed of extremely tough collagenous tissue and has no nerves or blood vessels or its central area, it can bear stress that could cause traumatic inflammation in general soft tissue. Well, there is that entire paragraph basically saying we're not talking about bone to bone. Okay? It is this understanding that explains why eccentric relation is at such precise, repeatable endpoint, the apex of force position. It is this precise endpoint for the condyle disc assemblies that enable us to record centric relation with needle point accuracy. Really? That's what Dawson is saying. But if I go back to Nakazawa, okay, he says, since the disc is composed of extremely tough collagenous tissue and has no nerves or blood vessels in this central area, it can bear stresses that could cause traumatic inflammation in general soft tissue. He said it's a very stable position even under considerable stress, but he emphasized about collagenous tissue, the disc. And as I told you, there is synovial fluid. If I have collagenous tissue and synovial fluid, how is that going to make a pinpoint recording? Pinpoint recording is possible with hard surface, bone to bone, teeth to teeth. This is the example of why the author is not trying to deliberately mislead us. No, no, he's not. But all of us, including me, we all have a bias. This is what I meant when I was doing some literature review with some of you, that I said uh, the the authors can have their own bias. When you have two different people looking at the same study, they can have the same result. They can have two different conclusions. So to me, Dawson chooses, he uses the reference from Nakazawa, but he still uses that to justify his bone-to-bone comment. And this is the example why, when you are looking, if you really want to get into literature review, when they cite certain things to emphasize what they're saying, and if you think there is any question mark on it, you have to go to the source and you have to read the actual reference. That's why textbooks have references. Okay. But that does not mean, that does not guarantee that the author is using the same conclusion or interpretation as the author. I'm not suggesting either one is wrong. I'm just saying there is always a bias. I'm not suggesting that bias is wrong because we are all conditioned to look at things the way we look at things. We look at certain pictures the way we expect it to look. And that unfortunately applies to science as well. And one of the things that we need to get out of that is actually, let me rephrase that. One of the things that we have to learn through our study together here is to learn how to get out of that and try to be as objective as we can be. Okay. Now, the next paragraph. There is a second reason why forces should not be put on teeth to prevent complete seating of the condyle disc assembly. Now, I fundamentally do agree with a lot of things he's saying. And then I agree that if you have too much force, especially there are wrong forces on the teeth, that it does not allow full seating of the condyle. I agree with that. Okay. All right. Um, this has the effect of putting teeth in interference with the completely seated joints. He is absolutely right. When you have interference on the teeth, you're going to put interference in the joints, or the joints cannot be at peace. They are, at least one of them are going to be trying to get out of its socket position. Okay. And we will have a chance to talk about that later again. Okay. Now he's going into conclusion again. The next paragraph, as you will learn in future chapters, one of the major goals in treatment planning is determining the best way to get the posterior teeth out of the way. So the condyles can completely seat and anterior teeth can contact without having to displace the condyles from anterior relation. I'm from centric relation. The goal of a perfected occlusion is to have equal intensity, simultaneous contact on the posterior teeth when the condyles are completely seated at their uppermost bone stopping place. Anterior teeth should also contact at the same jaw position so the anterior guidance can do its job of discluding the posterior teeth the moment the mandible starts its excursive movements. I know it's confusing because they are three separate statements. They do not necessarily mean the same thing. This is why if somebody is reading this book on their own, I hate to tell you, you're only going to be confused. Because that one paragraph are telling you three different things. Okay? Let me go back again and 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 re-emphasize what I see. Okay? So I'm going back to the top of the paragraph again. One of the major goals in treatment planning is determining the best way to get the posterior teeth out of the way so the condyles can completely seat and anterior teeth can contact without having to displace the condyles from eccentric relation. So the only way anterior teeth can contact without having to displace the condyles from centric relation is if the anterior teeth are in no way forcing, quote unquote, forcing anterior guidance. If you're forcing anterior guidance, then you're putting some sort of a bodily positional force onto the condyle. Number one. Number two, the goal is to get the posterior teeth out of the way from interfering. Why do we only rely on the front teeth to do that in anterior guidance? Why not work on the shape of the posterior teeth so that they are not likely to run into each other? And this is what most of you are not well trained in. We need to learn to shape the posterior teeth so that they are not likely to run into each other, even if there is very mild anterior guidance or, God forbid, no anterior guidance. As I told you earlier about the example of the dentures and this and that about history, learning how to be good with denture, full denture, is a really, really good exercise in learning a lot about occlusion. In fact, A lot of the things about I learned about occlusion really comes initially from observation from complete denture things. Incomplete denture, incomplete denture. You cannot, I'm not talking about implant with a retained denture. I'm talking about conventional complete denture. Okay. You cannot have anterior guidance, canine guidance. If you do, your denture gets loose. In fact, that's one of the main reasons why so many people's dentures don't stay in place. The only way your dentures are going to be stable is if you have good posterior contact, bilateral, even. Don't you think it actually is similar idea? If the dentures are able to be stable by having just a posterior contact, wouldn't that translate to if you had actual teeth or the implants that are founded inside the bone? That's the same idea if you have bilateral posterior support. Okay. That anterior contact, it is theoretically possible to have anterior simultaneous contact uh, in at least class 1 occlusion patients that will give you occlusal stability. The only problem is because the condyle or the TMJ elements are not pinpoint, needle point accuracy, you need to have some room to play. It's almost like saying, what came to me just now is, I don't care how good your car is. Can you imagine instead of having a rubber tire, if your car had a steel wheel like a train? If you had a steel wheel like a train, you don't have to worry about getting flat tire. You don't have to worry about um, having a having to replace tire. But take a look at the trains. How fast can they stop? Not really. And unless you ride in a really, really, really expensive, advanced train, how does the quality of ride compare in a train ride to that of a nice car? Right? There has to be some point where it sort of smooths things out. Okay? Teeth are hard, bone are hard, bones are hard. The cartilage or the meniscus and the ligaments and the synovial fluid is what makes that contact points function well without having to break down. Okay? So remember that. Okay. So now I am going to, the last paragraph is obvious. We've said this many, many times. Okay. That understanding TMJ because of all these is critical before we consider changing something about occlusion. Okay. Now it's 11:15, 11:16. Why don't we take a 15-minute break? Because you allowed me to talk basically nonstop for about 2 hours. So I need a little break time. Okay. So why don't we regroup again at 11:30 and we're gonna go until about somewhere between 12:30 and 1 o'clock. Okay. So the mascatory musculature. It says the principle is the purpose of all occlusal therapy is a peaceful neuromusculature. Well, I'm not sure about that, but I mean certainly, neuromusculature that's peaceful is something that's going to be very helpful for us. you know, I think the quotes in page 46 are helpful for us to drive the point. Um, you know, when the bone and the muscles war, muscle never loses. When the teeth and the muscles war, muscle never loses. I mean, certainly true. But but muscles, just because they win the battle, win the war, does not mean that they are free from scars of the battle, meaning that the muscles also suffer. Okay. And that is something that we need to learn how they may suffer and what kind of problems that we can anticipate. Okay. So I'm going to read a few things to sort of lay down the groundwork here. The dominant determinant. We cannot keep teeth in stable position where muscle does not want them to be. Muscle is the dominant determinant of both the horizontal and vertical position of the teeth. And this is something that's obvious, but that's also sometimes it's actually at least difficult to drive the point to with patients. Oftentimes, when they feel slight different teeth contact, they think it's the teeth that moved. And I have to somehow find a way to explain to them, no, it's actually your jaw, that posture, the jaw movement that changed. Certainly, teeth move too, but we have to be aware of the relationship with the jaw. The next sentence says the compressive force of the jaw closing musculature has been measured up to 975 pounds per square inch. That's quite a bit of force. Okay. The devastation that aberrant um, muscle forces can wreak on the musculatory system goes beyond teeth. Incoordinated, hyperactive musculature can, over time, displace the disc from condyle, cause a variety of structural deformations to the temporomandibular joints. Mandibular joints. Muscle is the primary focus in vertical dimension, the neutral zone, arch form, occlusal disease, orofacial pain, and even smile design. If muscle is not a prime consideration in treatment planning for prosthodontics, restorative dentistry, implant, orthodontic, or maxillofacial surgery, predictability of treatment results will be reduced to guessing. And without making it too much more complicated, uh, it is absolutely true. Now, as Dawson previously talked about, it's actually relatively simple to do to appease the muscle. He said, he already told us, make sure posterior teeth are having any interferences. If you have posterior teeth that don't give any interference, then your muscles are going to be at peace. He already said that, assuming that you're at a proper vertical dimension. Okay. He talks about how EKG or EMG, electromyography studies, okay, have expanded our knowledge. Okay. All right. And that the communication between the teeth and the musculature is far more coordinated and exquisite than we had ever thought about. Okay. And that when you're looking at the muscle coordination, okay, that these are all the things that we need to be aware of. Now, when most of you don't think about this here, on the drawing on the right side of page 47, okay, the way I look at it, to be honest with you, you don't need to memorize how each muscle moves at opening or closing or things like that. Okay. What you do need to remember is that when your mouth is opening or when your jaw is going forward, okay, there are different muscles that are working. But that poor lateral pterygoid, if you look at that picture, top picture and bottom picture, you see how the superior belly of the lateral pterygoid and inferior belly of the lateral pterygoid, they're almost at opposite of each other all the time. All the other muscles are far apart from each other, so we kind of understand. Okay. But the complexity in the system that dictated that dictated the lateral pterygoid muscle to develop the way it did, that's potentially the weak link in our system. So I want you to remember, because what this is going to come up again. Take a look at the picture. Blue, which is the superior belly of the lateral pterygoid. Where is it attached to? It's attached to the disc. The red, the inferior belly of the lateral pterygoid. Where is it attached to? Neck of the condyle. Okay? So we call it same muscle, lateral pterygoid. But maybe we should start calling it different names because they almost always oppose each other. One muscle oppose each other. Okay? So no, that's one thing that we think about. We always think about uh, um, the temporalis muscle. We think about the masseter muscle, and the one that's going up and down just behind the masseter muscle, that's medial pterygoid, just in case if you're wondering. Okay? And then the one below the jaw, we don't actually think about that. Okay? The digastric, right? And then I believe, I don't know, hyosternocleido, whatever, hyoid bone that's attached to the neck. Let's just put it that way. Okay? All those muscles are all working together. And we just need to remember that these muscles are moving our jaw. I think that's probably, to be honest with you, that's really all I think about. I do think about lateral pterygoid when I'm seeing patients. Okay. Okay. Especially if I think they are having pain in the joint or their joints are unstable. Then I do specifically think about lateral pterygoid because I want to find a way to calm down the lateral pterygoid. Okay. But when you go through the next series of all the drawings, okay, I don't want to bore you too much, but let's just talk about 48, page 48 on the upper left, coordinated muscle function and maximal inner cuspation. Okay, when all the things are working properly, when all the things are working properly, that's basically CR. You can call it maximal inner cuspation at CR. Okay, that when you start to have disharmony in the system, where the jaw position is working to try to make it work, and that inferior lateral pterygoid is moving the jaw forward to try to make it work. Why did I picture it that way? Because for the mandible, moving the jaw slightly forward is almost a natural thing to do because it's so easy to do. So if there is a wrong occlusal contact, one of the first things the jaw will try to do is to get out of its way, the occlusal interference, by pushing the jaw forward. But that's the beginning of throwing you off in catching where the occlusion problem is. Okay? And that when it gets into that forward avoidance posture, you can call that a CO or habitual bite or whatever it is, depending on how severely different that is from the CR position. Okay, and when that out of its position gets more prolonged, or they stay in and out of the place for a long time, then you start to have TMJ disc that may get displaced because it's spending too much time out of its position. And that's the figure 6-1. Okay. Now, he calls it on page 49, okay, on the left-hand column, okay. Do, 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 do. Let's start with the very first paragraph and first sentence. Occlusal interferences that require displacement of the TMJs to achieve maximal intercuspation of the teeth can cause incoordination of all the musculatory neuromusculature. So occlusal interference, when you have occlusal interference, okay, it can cause a ripple effect onto all of the muscles. The question is, how severe is the occlusal interference? Most of the times we're not aware of it. This is called occlusal muscle pain. Okay, I don't think other disciplines call it that way, but okay, he wants to call it that way. And he cites number 16, 17 in reference. I'm just going to go back and 16 and 17. And they are, one is Ramford and second one is Dawson. And Ramford is 1961, Dawson is in 2003 or 1990 and 2003. So I'm going to give the credit to Ramford. Okay. Occlusal muscle pain. Fine, fine. Okay. It is one of the most common musculatory system disorders and is the cause of most of the so-called TMD pain. It is also one of the most predictably correctable cause for pain in the musculatory system. Occlusal equilibration is more often than not the choice of treatment, but only after carefully diagnosis and determination that equilibration is the best choice of 5 treatment options. Well, I'm here to tell you equilibration is not number one choice, at least not in sequence. The number one choice is most of the times splint therapy, or what I like to call mandibular deprogramming stabilizer therapy. Okay? That allows no posterior interference to get in the way. Without, and this is reversible, right? Because we're not touching the teeth yet. That's, now, I know many patients don't want to pay for that, but that does not mean that we give in to them. Okay? If it's an existing patient, you have a history, that's one thing. But you have to be careful. I think I told all of you my experience of my own patients. I had a patient that I did not charge for the occlusal equilibration. I was doing it in the midst of doing composite restorations because I wanted the composites to stay on longer. That I offered to do some occlusal equilibration on the patient where he had clearly some occlusal problems. And yet the patient's wife, who was an attorney, tried to sue me because I didn't obtain proper informed consent, separate informed consent for occlusal treatment, occlusal adjustment. You have to be careful. Okay. So yes, occlusal equilibration is helpful. I do this on many, many patients, but only if I feel it's safe for me and the patient has expressly consented and understands what we're about to do. And that is grinding teeth that otherwise have no other problem. And I tell them, well, what good is it holding on to that extra zero point 0.2 millimeters of enamel if holding on to that means you continue to have pain, either in the tooth or in the muscle, or headaches, or continued breakdown of your occlusal system. And quite likely, oftentimes, you lose the whole tooth. Okay. But but this is one part that I caution you. Okay. This is where occlusal therapy starts with splint therapy first. Okay, next part. Muscle response to occlusal interference. This is important. Okay. When an occlusal interference such as a high restoration is introduced into a comfortable mouth, it typically evokes a response of hyperactivity and uncoordinated contractions in all the muscles that are prevented from functioning in a coordinated pattern of contraction versus release of opposing muscles. 6-2. Okay. It is also common for the interfering tooth to become sensitive and sore because of the prolonged hyperactivity of all of the temporal muscles. Tension headaches in that region often occur in combination with pain in the masseter muscles and in the pterygoid complex. This is exactly what most of the orofacial pain patients describe. And I literally have had thousands of patients in my career where their complaints have been resolved by providing either splint, mandibular deprogramming stabilizing therapy, and or occlusal equilibration. I have had, to my recollection, 3 patients where I did not have a chance to confirm that. Why? Because they did not come back. They didn't come back maybe because they thought I was quack. We didn't do them any good. Those are possibilities. But even if they turned out to be miserable failures, 3 out of thousands, I say that's a pretty good argument. Now, one can say, well, Dr. Lee, collection of anecdotal reports are not science. I say that is true. That is not peer reviewed. But at the same time, uh, poorly designed and poorly observed studies are not that much better either. Okay, let's move on. There is no more convincing evidence of the relationship of occlusal interference to masculatory muscle pain than the response achieved by separating the interfering teeth from contact. Placement of a simple, flat interocclusal device on the anterior teeth separates the posterior teeth and allows the TMJ to completely seat up into centric relation. This permits the lateral pterygoid muscles to release contraction and results in return to coordinated muscle function. So they just described to you NTI or anterior jig. They can work reasonably well as long as you do that while the patient is awake and patient is not chewing and patient is not engaged in social function like talking. But if you expect them to sleep with it, that's not going to work. If you expect them to chew with it, that's not going to work. Okay? So they describe this various iterations of anterior jig later on, but uh, but you know you have to remember, yes, it does illustrate to us the importance of getting rid of posterior interferences, okay, but that's not necessarily how we want to center our therapeutic approach based on. Okay. So let's talk about this. The next page, page 50. Muscle response to posterior disclusion. This is interesting how they make these such bold statements. Irrefutable evidence for the role of occlusal interferences has been provided by Williamson, Mahan et al., and many other investigators. the comparison of uh, muscle hyperactivity versus peaceful coordination is easily demonstrated by what happens within the mascatory muscle complex when the posterior teeth are separated during protrusive and lateral excursions of the mandible. At the moment of separation of the posterior teeth, almost all of the elevator muscles shut off. Let's just stop right there. Now, it's unfortunate that they don't actually illustrate one more thing, and that is this. At the moment of separation of the posterior teeth that were in interferences, that's the part that's missing. If the posterior teeth are in good harmony, they are not in hyperactivity. Okay? So in their effort to emphasize this, I think they sometimes get a little off the balance there. Okay? This has three beneficial benefits: great reduced horizontal forces against the anterior teeth, which are the only teeth in contact during excursions. So they are saying that horizontal forces against the anterior teeth may become excessive. So remember that statement before you give them strong anterior guidance. Okay? It reduces the compressive loading forces on the TMJ. Okay, fine. It makes it impossible to overload or wear the posterior teeth even if the patient bruxes. Hmm, I don't know about impossible, but I put it this way to you. From my own experience, here's one thing I can tell you. One's occlusion cannot be perfect all the time. Why is that? Because our joints, so far we talked about the meniscus, the capsule, synovial fluid, the ligaments. Now we're talking about the muscles. And I told you that they're slightly compressible and this and that. Because of that, every day, depending on what we're eating, okay, and how our jaw, the bone lines up and how our muscle moves them, okay, some people's occlusion are just one step in the right side of being non-traumatic. But if you insist on eating hard food, when you eat hard food, that's like driving your car into the mountain range, in the gravel road, stone road. Your system will wear down faster. Because when I'm chewing down on hard food on my left side, my ligament, my capsule that's holding my joint on the right side keeps getting stretched besides just the left side. And then when they're getting stretched, then it gets even looser. Now, if the eating of the hard food was only once in many days, then your system will have a chance to heal itself or recover from it. But if you keep doing that every day, every meal, then the stretched ligaments will start to have an adaptive physiological change. So frankly, this is something I don't like to say openly, but I will say if all of us live long enough, if you want to have healthy dentition and mascatory system, almost all of us will benefit from a well-made mandibular deprogramming stabilizer because every night it allows your jaw system musculature to have make sure there is zero posterior interference nor too much anterior force. Allows your musculature to relax. And even if your system is clenching, it is making sure that there is no interference lateral loading. Okay. One of the things that I thought that was really helpful for us to remember is this. On page 51, he talks about the different terms that we use. Fulcrum, we understand that. Force, we understand that. Load, we understand that. Tension, we understand that. We often don't talk about strain. Strain into the system. When somebody's occlusion is not good, it puts a strain on the system. And what does it do? It tries to force a change in the shape of the things. So, it's if you have a car that you want the car to last a long time, you don't want to drive like a maniac. We all know that, right? You don't want to be flooring. You don't want to be racing at every red light. And even if it's a truck, you don't want to be driving on a mountain, rock laden rubble road. You want to drive it a nice, smooth road. Okay. And that's where my perspective comes from when I encourage my patients. Don't don't eat too much hard food. Now, I'm not suggesting if we that people never eat any hard food. Of course, we have to sometimes, right? Okay. But we're all gonna live much, much longer than our previous generations. And if you expect your system to survive for a long time, then you want to reduce the load so they have a much longer lifespan. Okay? So, so that when you take a look at the next page 52, muscle incoordination as a causative factor in disc derangement. So, when we talk about this, how the picture is and so forth, it 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 goes where the disc is anteriorly displaced. Okay, the picture there. Okay. They talk about how they talk about how if you look at the arrow in the head of the condyle keeps on going posterior. One of the things that almost always accompanies anterior disc derangement is condyle that goes backwards. And what is almost always correlated to condyle going backwards posteriorly is too strong of an anterior contact or lack of posterior support. I see these all the time. Okay. And because the muscles are trying to fight this, they get fatigued. When they get fatigued, they don't work as well. They lose the ability to coordinate. So lateral pterygoid, the poor thing, they suffer all the time. They get too tired. Okay. On the right side in page 53, first paragraph on the left side, about halfway down, Dawson says, it has been my consistent clinical finding that whenever I find discomfort or dysfunction, I will also find muscle incoordination. I agree. Since muscle incoordination can so easily start a chain reaction of structural deformation. It is necessary to determine whether muscle incoordination is the cause or the result of the structural malrelationship. In my clinical experience, it is an extreme rarity to find masculatory muscle incoordination without a definitive structural disharmony as the activating trigger for the muscle hyperactivity and incoordination. It is also my clinical experience that removal or correction of the structural disharmony results in return to normal muscle function and comfort. Okay, so it is really we see that muscle is the one that's always overworked. And that's where we're going to initially pay for when we have occlusal problems. Okay. Now, let's read the next one, the mascatory muscle. Okay. It is helpful to divide the muscles of mascation into positional muscles and the elevator muscles. The positional muscles are responsible for the horizontal movement of the mandible from centric relation. The inferior lateral pterygoid muscle pulls the condyle down and forward, and the elevator muscles pull the mandible back and up. The superior lateral pterygoid muscle is responsible for keeping the disc properly aligned with the condyle during function. Okay? The elevator muscles are all positioned distal to the teeth so that they elevate the condyles and hold them firmly against the eminence while hinging the jaw. The masseter, the internal pterygoid, and the or medial pterygoid, and the major part of the temporal muscles are responsible for elevation. In the normal resting position of the mandible, the elevator muscles and their antagonistic depressor muscles are in a resting state of postural contraction. The mandible is balanced between them. The mandible is always balanced in between the elevator muscles or the positional muscles and depressor muscles. Okay? When they go out of balance, that's when we start to have problems. Okay? All right. Well, I'm gonna just kind of skip it where like I told you, we don't need to know incredible detail about all these. Okay. Okay. Hold on one sec. Okay, good. Okay. Now, here is the thing. The importance of occlusal harmony on the right side at the bottom. Ideal mandibular function results from a harmonious interrelationship of all muscles that move the jaw. Muscles become fatigued if it is not allowed to rest. Muscles should not be forced into prolonged activity with no chance to rest. When teeth are added to the stomatognathing system, they can exert a unique influence on the entire inner balance of the system because of the inner cuspation of the teeth is not in harmony with the joint ligament muscle balance. A stressful and tiresome protective role is forced onto the muscles. So, some of you have heard me describe to my patients when they come in and they have these pain around the TMJ joint. The way that I often explain to them, especially when I palpate and they have a positive finding on muscle palpation, would be I tell them it's kind of like your muscle has overworked to the point where your muscle is just knotted up like this. And you know how when you do massage, they will what? They hurt. There's a trigger point. So when I'm palpating, if I have certain trigger points, I know that those muscles are overworked. Okay. So if they are overworked, guess what can happen? Not only are they overworked and they are tired, when you touch them, they feel a little tender. If they are really, really, really tired, now this happens to you when you get old with no reason, but when you are young, when you get really, really tired, sometimes you get muscle spasms, right? So when you get a muscle spasm in your pterygoid muscles, it gives people headache or pain in the region like no other pain because it's like having a cramp. And don't bother with pain pills if you suspect that's what they're having because pain pills don't help you when you have muscle uh, cramping, muscle spasm. Okay, if you want to give them medication, it's got to be muscle relaxants or give them an occlusal relationship that the muscles don't have to work hard. What would that be? If you want to start out with the splint therapy, flat plane, no posterior interference, and to an extended sense, no anterior interference. I'm going to call very strong anterior guidance. I'm going to call that as a anterior interference. Okay. Okay. Excuse me. On the next page, page 54, the second paragraph, the lateral pterygoid muscles are capable of holding the condyles during a protrusive function, but in the presence of an occlusal interference, they can never be relieved of this function without allowing the malaligned teeth to be stressed. So like I said, if the malaligned or hyperocclusion teeth are in place, the lateral pterygoid is trying to pull the mandible away from it by pulling it forward. And it cannot relax until your interference is gone. Okay? The mechanism that forces this prolonged contraction onto the lateral pterygoid muscles is the exquisitely sensitive protective reflex system that guards the teeth and their supporting structures against excessive stress. Mechanoreceptor nerves, mechanoreceptor nerve endings scattered throughout the periodontal ligaments are sensitive to even minute pressure on individual teeth. How much minute pressure? Some of you remember what I quote when I quoted the literature. Human beings have been demonstrated to have sensitivity down to 1/100th of a millimeter. Okay, 10 microns. Okay, okay. Now, somewhere down the road in the same paragraph, I'm going to say about halfway down that page on the left-hand column, slightly up, a couple of lines up from the midpoint. If tooth interferences cause the mandible to move left, the right lateral pterygoid must contract to pull condyle forward. Contraction of the left pterygoid moves the jaw to the right. Contraction of both pterygoids moves the jaw forward. Okay. So the lateral pterygoid, you have to remember what I said earlier. We tend to look at, because of the drawings, that right and left is going to always have the same movements. It does not. Okay. It does not have the same movements. We have to keep that in mind. Okay. Now, so the next sentence is there are unlimited variations of timing and degree of muscle contractions to precisely position the mandible for maximal intercuspation of the teeth. But the lateral pterygoid muscles are always involved in any deviation from the centric relation. That's why lateral pterygoid is always involved, almost always involved with occlusal problems. Because it's the lateral pterygoid that allows our jaw to go sideways also. Now, it's interesting, it says, and this is from their EKG findings, The next sentence, next paragraph, the muscles cannot relax the protective bracing contraction as long as the occlusal interferences are present. The pattern of deviation is reinforced every time contact is made, and it is retained in the brain's memory bank so that muscular closure into the deviated jaw relationship becomes automatic. When they become automatic, what do we call it? We call that programmed, right? The jaw has learned to avoid it. One important facet of the mechanoreceptor memory, however, is that it fades rapidly if continual reinforcement of the pattern ceases. Meaning, like as soon as you get rid of the interference, the muscles will start to recover. So imagine if somebody does not have a perfect occlusion, and if they're not eating too much of hard food, if all they did at nighttime was to wear my mandibular deprogramming stabilizer, every night they heal a little bit, even if during daytime their occlusion is not perfect. Okay, that's how we create an environment where without where the splint therapy can be useful for our patients. Okay. Okay. Now, one important facet of the mechanoreceptor memory, however, is that it fades rapidly if continual reinforcement of the pattern ceases. Deprogramming. Elimination of interfering context permits an almost immediate response to normal muscle function. The deviation pattern is forgotten as soon as it is no longer needed. Okay. I'm going to say that actually takes a little bit more time, but the effects are almost immediate starting. That's true. Okay. So now next paragraph on the right-hand column of page 54. Williamson demonstrated the precise effect of occlusal interferences on muscle coordination and normal muscle activity. Using electromyographic procedures, he showed that interfering contacts on posterior teeth in any eccentric position caused hyperactivity of the elevator muscles. So you have to remember this. Not posterior contact, as in all posterior contact. No, only eccentric, meaning lateral loading. That's the problem child. Okay? But if the anterior guidance was allowed to exclude all posterior teeth from any contact other than centric relation, the elevator muscle either stopped active contraction or noticeably reduced in the moment the posterior teeth were excluded. So reading that, you can logically conclude, even if I don't have anterior guidance, if I don't have posterior teeth that are interfering, then it's fine. It's no different than having anterior guidance. Or you don't have to rely on anterior guidance as much. Okay? If heavy contact on any posterior tooth in any eccentric position causes a response of muscle hyperactivity, it has the effect of loading the tooth or teeth with the occlusal interferences. But the elevator muscle hypercontraction also loads the joint with the same hyperactivity. Okay. So, the teeth, it becomes muscle problem. Muscle problem becomes the disc problem, ligament problem, and so forth and so forth. Okay. Now I'm going to skip over down to a little bit. I'm going to skip two short paragraphs. The next one. An incoordinated musculature rarely exists without causing some form of adaptive structural change. Because of their tendency to wear, become loose, or move, the teeth are the usual focus of structural alteration. The TMJs has generally been regarded as the most stable component of the masticatory system, but remodeling can change the shape of the disc or the condyles. Okay. Okay, Mylene, hold on one sec. Okay, let me just finish this. Mangini has shown that direct relationship exists between the shape of the condyle after remodeling and the attrition patterns on the teeth. His findings give support to the concept that remodeling of the joint can be considered, to a certain extent, a functional adaptation to occlusal disharmony. And some of you may remember Mangini article, or at least one of the Mangini articles is something that I cite in my lectures to precisely talk about this, that that morphologic change of the bone occurs in our body as it relates to the occlusion. Okay. Sure, Mylene, yes. I was hoping somebody was going to talk besides me today. Thank you.
I'll give you a second.
Thank
But
you.
I'm just wondering, like, this thing. So if you have a bolus of food in the back, your teeth are separate. Your posterior teeth are separated. They're not touching. How could the elevator muscles not be firing? Like it says that like if your posterior teeth are not touching, the elevator muscles relax. But if you have a bolus of food, your teeth are not touching, but the elevator muscles must be firing.
Oh, of course, I think you're absolutely right. Well, I think what they're talking about is not while you're eating. And that's exactly the point that I'm trying to make. When they keep emphasizing disclusion of the posterior teeth and you just load up the anterior, that's why I keep saying you cannot rebuild masticatory system based on that concept. You can get those people out of pain by giving them anti Lucius jig, anterior jig, and whatever you want to call it. Okay. But from a practical perspective of chewing food and somebody whose teeth are coming in contact, okay, you cannot create an environment where posterior teeth are not in contact and the musculature will be in peace. That is
I
that
have
is
another question though.
pardon, go ahead.
Yeah, sorry. So what happens when you have a a splint? You're wearing a splint, the posterior teeth are discluded.
Well, if you're wearing a splint, posterior teeth are not really discluded because they are contacting the acrylic. At least the
So
way
will the
that I
muscles be
design it,
firing
the way
then?
that I design it, right?
And so the muscles will be firing or
The
they're in
muscles are
rested state.
firing according to what Dawson said if they're touching eccentrically. So if the muscle, if the teeth are having flat acrylic to the cuspal tip, they're not really firing like crazy. They may be firing a little bit because it's impossible to only have straight up and down. There may be some force sideways a little bit, okay? But the idea is you want to create posterior teeth on their own that do not cause interference, lateral loading, which they have demonstrated repeatedly, it causes hyperactivity of the muscles.
Right. So basically what it is it gives them a rested state. So like the splint gives it a rested state.
That's right. They can rest. Yes. Or even if
Because the
their
muscles are coordinated.
muscles are coordinated, yes, they can rest. You're absolutely right. So even if they're
Is that
clenching,
research?
yes.
Sorry. Got you. Yeah. So is that research in the Williamson and the Mahan study?
Uh,
The proof
well,
of the muscle firing,
yes, I mean, well,
hyperactivity?
they are primarily responsible for a lot of the studies in their the EKG studies, EMG studies.
So how can the oral facial pain people not recognize the science behind the muscles hyperactivity in lateral? Like, how do they not recognize that research?
Because if you take courses with orofacial pain people, they have moved away from muscles and they are becoming somewhat of a subspecialty of neurology. They
Okay,
are
thank you so
moving
much.
away from this mechanical model of mastication. They are trying to separate orofacial pain separated from masticatory system. That's why they keep saying it has nothing to do with occlusion. And that's why I wanted you, especially after you and I had the long conversation, Mylene, I wanted you, to be part of our discussion with this group, okay? Because especially with your strong restorative background, it is impossible to separate them out, okay? And this is exactly why, you know, I still consider Dawson's book to be very, very helpful for us in our journey to understand this because Dawson lays down a pretty good argument for all the things that we need to be aware of as a restorative dentist. Okay, I hope that was helpful. Okay, all right. So now let's read a little bit more here. The apex of force positioning of the condyle seems to relate rather consistently with Mangini's findings regarding the relationship between the type of displacement and condylar shape by remodeling. He showed that flattening and flaring of the anterior surface are the most common changes in condylar shape and are accompanied in most cases by anterior condylar displacement. Remodeling of the posterior surface of the condyle leading to flattening or concavity is common in posterior displacement. When all the notable related research of the past few years is analyzed, it is apparent that the occlusal interface must involve the articulating surface of the TMJs with equal importance to the occlusal surface of the teeth. So we want to stabilize the disc in the right place. But remember what I said earlier. Disc tends to be anteriorly positioning if you have inadequate posterior support or front teeth touch too much. And that is why evaluation of that and providing mandibular deprogramming stabilizer is so helpful. Okay. Now he sort of summarizes on the next page 55 the sentence. It says successful occlusal treatment is dependent on complete harmony of all the passive and active components of a very precise and complex system. It is not possible to have an adequate understanding of occlusion outside of the framework of the total stomatognathig system. Now, centric relation is something that's going to require a little bit of discussion because I don't want to rush through this. So it's almost, we're at 12:25. So I'm going to start talking about it a little bit, and I hope that you're going to maybe reread this chapter again, and then we're going to come back and review it one more time because this is actually very important. And then subsequent chapters about how to record, da 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 da. Okay, because now we're getting into some clinical dentistry, right? Okay, so I had you read up to 101, not because I was expecting to go all the way up there. I was hoping not because that means I kind of got a little too tired or I just rushed through. Okay. Um, but this is extremely important. I don't want to confuse you. So I hope that I can lay down some starting point today and then we'll continue next month after you have some thoughts about it.
Dr. Lee,
Yes,
one question. Okay.
please do.
Completely confused, okay?
Yes,
Okay. So you said earlier that when we lack posterior support, right, the disc moves forward, right?
this tends to move forward. Yes.
Tends to move forward. Okay. So what happens when we lack posterior support? And I know it's different versus having posterior interferences.
Oh, excellent point. So when you have posterior interferences, it depends on what kind of interference, right?
Mhm.
Obviously.
Yeah.
But you can think, let's just talk about only one interference on the left side.
Mhm.
Okay. When you are interfering on the left side, and then when you're biting down, you only touch the left side
Mhm.
because somebody gave me a high crown.
Mhm.
What's going to happen is when when the muscle is biting down, when the chewing is occurring
Mhm.
or closing is occurring, okay, muscles are firing on both sides. Now, if you have food on the left side, then your muscles are preferentially forcing stronger contact on the left side and your jaws shifting a little bit sideways. Okay.
Okay.
I do like this AI technology where Zoom is automatically zooming in and out of my face. I just recognized it. Okay.
Fantastic.
Okay. Now, so if you are just clenching, let's just talk about that. If you're
Okay.
just clenching, no food, you're just high on the left side, you're clenching.
Mhm.
Your jaw goes up, the left side, there's stopping point.
Mhm.
My right side, gonna go up a little bit more,
Mhm.
right? You follow that, right? When it does that, my if my condyle was in the right place, in the
Mhm.
centric relation position, okay, my right condyle will go up further.
Higher. Mhm.
Instead of just being at superior anterior, now it's going to go up a little bit further up,
Okay.
right? When it goes up a little bit further, what's going to happen to the disc that was slightly in front of it? It's
Mm.
going to,
Gonna slide backward. Mhm.
no, it's going to slide forward more
Why?
because my condyles keep going. My, this is the condyle. My disc is like this. No,
Oh, because it
this
went
side is the front.
forward, so it's gonna go forward. Okay, got it.
Yeah, it
Mhm.
gets slipped like
Okay.
this.
Okay. Mhm.
So bigger the bigger the height difference of the crown,
Mhm.
more of the problem will be
Mhm.
pronounced, right?
Okay.
Now your pterygoid muscles, lateral pterygoid muscles, the superior and the inferior,
Mhm.
they're gonna try to stabilize this disc,
Mhm.
so they get tired. So even though your bite is off on the right side, your pterygoid muscle usually gets
Mhm.
more fatigued on the left side,
Opposite side.
opposite side.
Okay.
That's not always the case,
Mhm.
but that's one. Now, now let's think about now if somebody doesn't really have a significant a high occlusion,
Mhm.
but somebody who has a little bit of that, and
Mhm.
then somebody who just likes to eat almonds every day.
Mhm.
In that case, when you just look at the teeth, you don't see that much difference, right?
Mhm.
But in function, same thing is happening. On the right, when you chew on your right side all the time,
Mhm.
okay, okay, your left condyle keeps getting moving around more, goes up more, back more, forward more, whatever.
Mhm.
When you keep doing that for years, your capsule, your ligament that wraps my condyle so it doesn't move around, what happens? They get looser
Okay.
because every day it's been stretching, right?
Yeah. Following.
Yeah. And every day when it gets stretched, now you have a greater chance of the disc getting
Um,
displaced either
mhm.
to the forward, either to the back, either to the side, or
Mhm.
to the inside.
Mm. No.
Okay, so
Mhm.
you see that. So that's what occurs most of the times when you have unilateral posterior interference.
Answer so
When
far.
you just have anterior interference, when you don't have adequate posterior support,
Mhm.
what it's not so much of a chewing function, but when they clench, now you have it's not the disc that goes forward so much. It's just the condyle is the one that keeps wanting to go back.
Mhm.
Disc is where they are. It's condyle that keeps going back.
Okay.
Okay,
Mm.
and it's the instability of that condyle and the disc that has this problem of unstable joint. And
Okay.
then your joints become, the muscles are hyperfiring everywhere because they are unstable. It's kind of like you're trying to balance yourself on one leg.
Mhm.
Okay?
Yep. Got it.
All right.
Thank you, Dr.
Thank
Lee.
you.
Okay.
Okay. Now, on chapter 7, centric relation, the first sentence that Dawson puts is principle. Centric relation is the only condylar position that permits an interference-free occlusion. I know why he's saying that, but I think it's such a misleading statement. So I'm gonna ask you to think about that statement. Okay, that is not true because the reason why I say that's not true is because you could easily be in centric relation and still have interference. So I know why he's saying that, but that is not true. I have to just categorically say that is not precise enough of a statement. You can be in centric relation and have interference. Okay. Now, when you look at the picture in page 58, figure 7-2, you have the two condyles and there is a bar that goes through connecting two condyles. And then they show you this diagram of jaw rotating around that bar, that fulcrum, that axis that connects right condyle to the left condyle. So in effect, they are working as two joints together as one joint. That is usually the illustration that people will say is they use the word kinematic hinge axis, meaning you have two joints, but they in terms of the purely mechanical movements, they act as if they are one joint. It's a useful concept, but it's only to describe movements. It's not about the anatomy. Okay? Now, I don't want to keep on repeating the same thing over and over. So I'm going to skip the first paragraph. I'm going to go to the second paragraph because now he wants to talk about understanding centric relation. Okay. Centric relation is the single most important factor of occlusion. I do agree. I do agree on that. Okay. Not because it's the word centric relation. How about if I say the word, how about if I express it like this? The ability for the TMJ joint to be in stress-free position is the most important part of the health of the joint. To me, centric relation is the most stress-free relationship. That's how I would like to define it. Not based on bone to bone, this and that or whatever. But when we are, how should I put it? When we are in stress-free position, that means the muscles are relaxed, right? So in that sense, it is somewhat, we're talking about the same thing, but I'd like to define using the word slightly differently. Determination of centric relation is the most important skill required for predictable occlusal treatment. I also agree with that. And it's unfortunately, mistaught to almost all of you when you were in dental school. Why? Because almost all of your professors learned from a book or learned from their teachers who were going back to 1960s and 70s. The same people that Dawson hung out with or taught. And that's why there is confusion. And I hope that after today and next month, there will be no more confusion about that. Well, there will be a little bit, but you'll be on your way to understanding. Verification of centric relation is an essential procedure in differential diagnosis of TMJ disorders. Recording of an accurate centric relation is critical for the most cost-effective, time-effective, trouble-free, restorative, or prosthetic dentistry. Centric relation refers to both the position and condition of the condyle disc assemblies. It is a specific position of the condylar axis. The condyle can be freely rotated on a fixed axis in centric relation up to about 20 millimeters of jaw opening without moving out of the fully seated position in their respective fossa. So remember, if your condyle is going back and forth when it's opening and closing, then you are not in CR. That is why earlier in the morning, remember I told you, when your patient opens their jaw so you can put the material into the mouth, and when you have them close to get the centric relation, if they close their mouth from maximum opening means open and then they slide like this. And if you put something in there and you have them bite down when they're trying to bite down from here, that's pretty cool. I like that camera. Okay. Okay. That is so easily out of the CR. So you have to get into the way of communicating to your patients, relax, and then close. Okay. It's kind of like going, I don't know if how I know that my assumption is that not all of you have had chiropractic adjustments in the back. Not that I'm advocating that because that stresses me out too. Okay, but you know can the chiropractor do your spine or your neck adjustments if you're like all tensed up? No. Okay. So, so one of the first criteria is the jaw has to be relaxed. Okay. All right. Now the next thing he says is, consequently, the mandible can be in centric relation even when the teeth are separated or even if there is no teeth in either jaw. Absolutely. Centric relation has nothing to do with the teeth. It has everything to do with the bone and the disc and the musculature. Remember what we said first thing today. We said everything else is in place first, and then the last thing goes in is the teeth. So every time when you are taking bite registration in CR, that's what you are trying to achieve. Now, if you're doing a simple filling and the rest of the occlusion does not seem to have a lot of problems, well then make it fit to rest of the teeth. But if you are trying to reinvent their occlusion, then your teeth better go in harmony with the bone and the muscles and the joints. And in such situations, such as full mouth implant restorations, dentures with or without implants. Okay. Okay. Anterior teeth restoration, large anterior teeth restoration. Whether you like it or not, how much anterior guidance you choose to give will have a significant impact to their mandibular posturing. You need to find centric relation. That's the starting point. And I'm so glad that I was able to come to at least centric relation topic today, because that's what we first set out to do. You remember the very first topic. That's why I told you today. I wanted to have you understand how this system gets put together. Teeth are the last part. Okay. And every time we're taking bite registration and centric relation, that is what we're trying to do. Now, when you are doing one tooth dentistry, I'll be honest, it's not as critical, assuming that rest of the mouth is not badly broken down. I do not, after all the years, and I see a lot of patients with problem in occlusion, I do not equilibrate everybody into CR. Okay? If I were to do that, many patients, I shouldn't say most, many patients will run away from me. Okay? Why? Because many people who have CR and their occlusion in disharmony, okay, live mostly normal life throughout their life. I think all of us, all of you, even the young ones, Iman, young ones, okay, even the young ones know by now you're not so young. You realize your body is not so perfect anymore, right? So our lives, our bodies, our system goes on without being perfect. The goal here is to make sure our systems last long enough so that we can achieve either nirvana or go to heaven. Okay? It does not have to last a millennium. It does not have to last 10,000 years. Okay? So, well, that is one thing that I wanted to share. Now, centric relation, it gives you this definition, sort of. I have to admit that's not exactly the definition that I agree with. But let's read it. Centric relation is the relationship of the mandible to the maxilla when properly aligned. Condyle disc assemblies are in the most superior position against the uh, eminence, irrespective of the vertical dimension or teeth position. I'm just going to have to say I agree with everything there, except it's not just superior, it's superior anterior. Okay? At the most superior position, or shall we say, most superior anterior position, the condyle disc assemblies are braced medially. Thus, centric relation is also the midpoint position. And if they, now here is and I don't have any problem with that. Okay, I hope you understand what they mean. Not mesially, medially. All they're saying is my mandible is not to the right or to the left. It's centered. Now, how centered they are, that depends on how well fitted between my maxilla and mandible is. Some of you have heard me jokingly telling my patients sometimes, God was a little too busy. God gave you um, bone that's large size, and the teeth were small, extra small, or vice versa. The bones were small, but teeth came in too big. In the same manner, you can have a maxilla that's big and mandible that's small. To me, that mismatch is what oftentimes explains class 2 and class 3. So if you have a mismatch of maxilla versus mandible, do you think that maybe there is some wiggle room for the condyle to be braced up against the medial limit? Medial, not mesial, medial limit of the eminentia fossa? Absolutely. That's why this idea about they have to be so precise, I'm going to say, hold it back a little bit. Okay? But they are in a non-constrained, non-deforming home position. Okay? A properly aligned condyle disc assembly in centric relation can resist maximum loading by elevator muscles with no sign of discomfort. Fine. They can chew maximum and have no pain in that position. But one thing that they did not include here is, remember what they said earlier. Where was it? Right before that, in that paragraph there. On the last paragraph on page 58, on the second sentence, it is a specific position of the condylar axis. The condyle can freely rotate. That's the next thing that I consider in clinical dentistry. Meaning that, and this is going to come up again, when I can discern, because I am doing a chin point where Dawson says it's not accurate. I understand that. And I think I explained to you why I do that, but we'll talk about that later again. The reason why I'm holding the patient's chin is not to push it back. Not at all. But is to see if it's purely rotating, just going up and down. If I notice that when I'm holding on to their chin, the jaw is coming forward, then I know I'm not in CR. I don't even need to see them. I just feel it. Okay? So I wanted to make sure that is the clinical basis for me personally. And that is indeed part of the definition of the glossary of prosthodontic terms. Okay, that's included in their terms. Definition of centric relation. Okay, where it is clinically discernible with pure rotary movement around the hinge. Okay, so remember that. Okay, remember these things that um, we're talking about. Okay, all right. So now I am being reminded that I have slightly almost gone over time. That's fine. Yeah, I think this is probably a good point for me to stop. I'm gonna give you opportunity for you to reread the chapter again based on what we have talked about so far. I think that would be a good way for you to kill rest of the day. Those of you who are in the cold country right now, right, go outside. Okay, you're gonna freeze your butt off. Okay, don't go outside. Okay, I grew up in Chicago. It can be quite cold. Okay, so okay, so it's a nice weather for you to make a nice soup at home. Okay, and do some reading. And when you start falling asleep, then take a nap. Be like a bear. Take a good hibernating nap. Okay. But I hope today's conversation was good. I don't know if it was conversation. Today's talk was good. Okay. But I wanted to sort of set up a stage for us to talk about now the centric relation and the role of centric relation and why, after having studied this book so many years, I first read this book during my residency. Okay. And I kept reading this book every time I have a study club that I start with. Okay. I cannot agree with Dawson about bimanual manipulation to find centric relation. So when you read the book, I just want you to know Tom Lee does not do it that way. But I want you to try to follow what Dawson is doing. And I want you to come back next month and tell me if that's what you think you can do clinically. Okay. I think all that is good. Now, we do have a couple of new people who wanted to see how things were going today. I appreciate you joining until the end. I know that you had other things going on, so it was a short notice. I appreciate that. The couple of thoughts that I wanted to just share with you. You notice that we had a few people less than last couple of times that we were together. And this is somewhat expected. This is one of the reasons why I really did not